Okay, we are live now. Manashwi, you can start.
Okay, thank you so much. Hello, namaste, and good afternoon. This is Manashwi, and on behalf of ForOptom, I welcome you all to ForOptom e-learning session. The ForOptom e-learning session is an initiative by ForOptom, and it is an interactive program where we discuss optometry topics. The session is live on YouTube, and if you have any queries, you can type them out in the conversation box, and we will be discussing them after the presentation. Today, we have with us Dr. Okechukwu Benedicta Nkonye, who will be speaking on the topic Management of Bacterial Corneal Ulcer. A brief introduction to our speaker here. Dr. Okechukwu Benedicta Nkonye is a primary eye care practitioner, currently working as a senior clinician and HOD of the eye clinic Okpuala Ngwa General Hospital, Abia State, Nigeria, under the Hospital Management Board of Abia State. She had done her BSc Optometry from the prestigious Manipal University, Manipal, India. And she has done her Doctor of Optometry from Kwame, Nkrumah, University of Science and Technology, Kumasi, Ghana. She is currently a candidate for an MSc in Clinical Optometry, Abia State University, Uturu, Nigeria. So on behalf of ForOptom team, I welcome you, ma'am.
Thank you. It's a beautiful morning here in Nigeria, Abia State, the eastern part of Nigeria. It's a great privilege and honor to make this presentation on management of bacterial corneal ulcer. I sincerely appreciate the ForOptom team for giving me their platform, and Mr. Avinash Prabhu. Thank you. For the benefit of today's discussion, we will be looking at Nigeria as a case study. Now, corneal ulcer. Corneal ulcer is an inflammatory or infective condition of the cornea involving disruption of the corneal epithelium. The corneal ulcer is one of the most ocular emergency causes that leads to significant vision loss and ocular mobility. And it might interest you to know that this has become a global issue and a public health issue too, because it is considered one of the major causes of developing corneal blindness, more especially in developing countries like ours. And it is also estimated to cause 1.5 to 2 million cases of corneal blindness annually in our countries. And the prevalence depends on the corneal ulcer, the type of geographical location, the causative organism responsible. Now, the causative organism responsible for corneal ulcer in various locations is different from that in another location. Bacteria, among all the various causes of bacterial infections of corneal ulcer, resulting in corneal ulcer, bacteria are the most common infective organisms responsible for ocular mobility.
I noticed it. Wow. You need to call her.
Hello?
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 Yes, ma'am.
Knock, knock. Knock, knock.
Yeah.
Come on, excuse me.
It
Don't
went
know the
off.
Wi-Fi. Does it go off?
Has it gone off?
Yes, I think so.
Hello?
Hello?
Hello? Can you hear me?
Can you hear me?
Yeah, I can hear you.
The screen is, the sharing has turned off. Could we try sharing the screen again?
Ma'am, can you share your PPT once again, please? It's not showing up.
Hello, are you with me?
Yes,
Yes,
ma'am.
ma'am.
Yes.
The presentation is visible.
Oh, okay. Sorry, it's network issues. It went off.
Hello, ma'am. Can you hear me?
Yeah, I can hear you.
Yes, ma'am. Let's start. Let's continue with the presentation.
We'll have to start all over again.
I'm sorry.
Do we have to start from introduction
No,
again?
we can pick it up from where we left off.
We can pick it up from where we stopped.
Okay.
Are you there?
Yes, ma'am. I'm there. Let's continue.
Okay, so I should start from the introduction all over.
No, we can start from where we left off. Where you stopped
Oh,
last time, we can just start from there.
okay. Okay, fine. So when you're ready, you let me know.
Yes, ma'am. We're ready. You can continue.
Okay. It's been estimated that corneal ulceration results in 1.5 to 2 million cases of corneal blindness annually in developing countries. And the prevalence of corneal ulcers varies according to the type, the geographical location, and the causative factor. There are so many causative factors responsible for corneal ulcers, and among these organisms responsible for corneal ulcer, bacteria are the most common effective organisms responsible for this ocular morbidity. And also, it is responsible for 90% of microbial keratitis. And the severity of the corneal infection also depends on the condition of the ulcer before the onset of the ulcer and the pathogenicity of the infecting bacteria. And it might interest you to know that without a predisposing factor, corneal ulcer cannot occur. and it is associated with ocular traumas of ocular surfaces. As a result of increased prevalence of use of contact lens, there is now an association between bacterial keratitis and contact lens wear. And the spectrum of corneal ulcer can also be influenced by climatic factors and geographic factors. If you watch, the organisms responsible in various places in developed nations are different from that responsible in developing nations. And also, based on the location within each nation, there could also be a variation in the presentation of the corneal ulcer from region to region, even within the same country. Take, for instance, in Nigeria, the predisposing factor of corneal ulcer in the northern part of Nigeria is different from the predisposing factor of corneal ulcer in the eastern part of Nigeria. In the northern part of Nigeria, where they are predominantly farmers, the way the ulcer will present and the causative organisms of the corneal ulcer is different from the way it will present in the east. And also in the northern part of Nigeria, where they have the cultural verification and religious beliefs, they believe that they don't give their children immunization. Most of the children in the northern part of Nigeria develop measles. And measles is one of the predisposing factors to developing corneal ulcer in children. But in the eastern part of Nigeria, it's not like that. And also one of the predisposing factors responsible for corneal ulcer in the eastern part is slowness to response. They prefer to patronize patent medicine dealers than reporting to the clinic immediately when they have problem. It is when they don't see solution that they will start looking for an eye center. So you see that the predisposing factor varies from region to region, even within the same country. Now let us look at a patient walking into your clinic with corneal ulcer. What are the symptoms the patient will present with? The patient will be complaining of severe pains. The patient will be complaining of photophobia as a result of inflammatory responses. And the patient will tell you, it just started all of a sudden. And also the patient will be concerned about reduced vision. There will also be redness, tearing, and discharge. And the clinical features the patient will be presenting with, there will be obvious epithelial defects, there will be stroma involvement, there will be edema of the cornea, and also the anterior chamber will show keratite precipitate with cells and flares, with hypopyon, and even emphysema. Now, having seen the clinical presentations, the symptoms the patient will be presenting with, you want to know what are the predisposing factors. Let's see in general, what are the predisposing factors that can expose one's cornea to developing corneal ulcer. We have trauma, eyelid conditions, ocular surface disorders, contact lens use, more especially in extended wear or soft contact lens. You have local immunosuppression as a result of prolonged usage of steroid or anti-glaucoma drugs. You can also develop in post-operative cases like cataract surgeries, LASIK, or patients who use traditional eye medication, like I've earlier stated, when trying to differentiate between predisposing factor in the northern part of Nigeria and predisposing factor in the eastern part of Nigeria. And you see measles in children. That is in general. And it will interest you to know too that in Nigeria, there are other predominant predisposing factors that could expose them to developing developing corneal ulcer that are not common in other places. And Nigerians believe in herbal medications, and so they would definitely want to try it first. It is when it doesn't resolve that they will now start looking for an alternative. Now let us look at the etiology. What are the main causes? We have various causes like infectious causes. We have non-infectious causes. Now, in the infectious causes of corneal ulcer, it can be as a result of a bacterial organisms, fungi organism, parasitic in the case of Acantha amoeba, and it's Acantha amoeba that is responsible for most corneal ulcers that develop in contact lens patients. It could be viral also. And based on the causal organisms, we have the various classification of corneal ulcers. Now, let us look at the various pathogens that are responsible for corneal ulceration. It might interest you to know that some researches has been carried out in other countries and in Nigeria, and they were able to isolate the most common causative pathogens that are responsible. If the organism is fungal organism, the common brand of that organism that is responsible is Fusarium species, Aspergillosis, and in bacteria, it is Staphylococcus aureus, Streptococcus, Pseudomonas, and coliform. While viral, it is Herpes simplex. Now let's look at the non-infectious causes. They are autoimmune from systemic conditions. It could be a neutrophy, that is degenerative conditions of the cornea. It could be a toxic response or an allergic keratitis. It can result to as a result of chemical bonds or keratitis secondary to eyelid conditions like entropion, trichiasis, and blepharitis. Now let us look at the classification. The classification is mainly based on the causal organisms. So if it is bacteria that is responsible, you have a bacterial corneal ulcer. And if it is fungi, you have a fungal corneal ulcer. And if it is viral, it is a viral corneal ulcer. And if it is parasitic, it is parasitic corneal ulcer. Now let's come over to the pathogenesis. Having known the various types of corneal ulcer reasons, as a result of this discussion and based on today's topic, we are looking mainly on bacteria. So our discussion will be limited to only bacteria corneal ulcers, the pathogenesis of bacterial corneal ulcer. And now there are 4 stages of development of corneal ulcer. The first stage, we have the stage of progressive infiltration. The second stage, we have the stage of active ulceration. The third stage is a stage of regression, and the last stage is a stage of cicatrization. Now, let's look. Naturally, you know that the cornea has a local defensive mechanism of preventing the eyeball from day-to-day infection. And some of these local defensive mechanisms are present in the tears in the form of lysozyme or other proteins. And also the eyelid, the eyelash, those are all the local defensive mechanisms of the cornea. And once this local defensive mechanism of the cornea is jeopardized, and there is a presence of any local ocular predisposing disease, or the immunity of the host is being compromised, there will be a compromisation of the corneal epithelium. If it occurs in the form of an abrasion, immediately there is compromisation of that corneal epithelium. The microbes will adhere to the epithelium. And when they adhere to the epithelium, there will be a release of toxic and lytic enzymes. In this process of release of lytic enzymes, that is a process of progressive infiltration. That is a stage of progressive infiltration, where it is characterized by infiltration of those lymphocytes into the compromised epithelium. And this comes from the peripheral circulation and also the underlying stroma. Now, after this has taken place, there will be response from the host. And subsequently, this will lead to necrosis of the tissues. And that will bring us to the next stage of active ulceration. In the stage of active ulceration is the stage where you see sludging and necrosis. And at that stage, there will be involvement of the Bowman's membrane and also the stroma. At this stage, what actually happens is the tissues at this level begin to absorb fluid. The fluid will be absorbed from the laminas of the tissue, and it will cause a swelling. So the walls of the ulcer will project as a result of that swelling. And at the same time, as a result of imbibition of the fluid and packaging of the masses of the lymphocyte between them. That is the stage of active ulceration. In this stage, the patient will be having hyperemia of the circumcorneal vessels, and also it will result in accumulation of purulent exudates of the cornea. Now, I want you to know that it wouldn't just stop there. There are other cascades that could occur. These exudates could as well move into the anterior chamber and they will cause the vessels of the anterior chamber, like the iris, the vessels projecting from the anterior chamber from vessels of the iris and ciliary bodies, that will lead to the formation of hypopyon. Now let us look at the stage of regression. This stage is a stage where there is healing. The healing is being induced. It's a stage where healing begins to occur. At this stage, it is induced as a result of the immune host response or the treatment being given. At the process of active regression, there is a line of demarcation that will form between the ulcer and around. In this stage is a stage where there is phagocytosis. At this stage of regression, phagocytosis will take place and it will give room to healing. There will be digestion of those necrotic debris that has already resulted as a result of enlargement of the corneal ulcer. Now, from the stage of regression, it will progress after the release of the free radicals, the proteolytic enzymes. There is necrosis and sludging of the epithelium. It will lead to a stage where you see the ulcer projecting from the wall, like I've earlier explained, and it will lead us to the stage of continuous wound healing. And at this stage of cicatrization, there will be a progressive epithelialization that will form a permanent covering that will lead to wound healing. Now, let us look at one important feature about the bacterial corneal ulcer. Bacterial corneal ulcer cannot just emanate without a compromise of the corneal epithelium. But there is an exception to this rule, and that is when it involves an organism known as gonococcus. Gonococcus infection can penetrate an inert epithelium to cause corneal ulcer without the epithelium being compromised. Now, when talking about bacterial corneal ulcer, you want to find out the differential diagnosis, because a patient can present to your clinic with all the symptoms, all the clinical features that look like bacterial corneal ulcer, but actually it's not bacterial corneal ulcer. So when you have a patient walking into your clinic, what are the differentials you'll be thinking of in your mind? You want to rule out fungal ulcer, bacteria. You want to rule out if it is actually bacterial ulcer for fungal ulcer. So the differential diagnosis for bacterial corneal ulcer are fungal, parasitic, atypical microbacteria, and staphylococci hypersensitivity. Now, it might interest you to know that in developing countries like ours, the most common organisms, like I had earlier mentioned, is bacteria and fungi. And these are the things that we're presenting more in our clinical setting. So you want to find out what are the features that a bacterial corneal ulcer presents that a fungal ulcer will not present. First, it will occur in the history. If a patient walks in with corneal ulcer, when a patient gives you a history of ocular trauma or a history of contact lens wear, definitely you begin to know that it is bacterial corneal ulcer. And if the patient gives you a history of trauma as a result of vegetative matter or soil particles, you will know it is a fungal organism that is involved. And also, the edema that the lid will present in bacterial corneal ulcer, it is minimal, irrespective of the redness and the pain the patient will present. And also, the bacterial corneal ulcer will present as a round ulcer or oval in shape, and it's usually present at the central part of the cornea or paracentral, and the rest part of the cornea will be clear. But in the case of fungal ulcer, it will be a grayish matter with a creamish infiltrate. And now, it will interest you to know that the inflammatory response of bacterial corneal ulcer is usually more aggressive than that in fungal ulcer. Now, having done the differential diagnosis, your patient has walked in, you will want to do a clinical workup for the patient. And what are all the diagnostic approach you will use to do your clinical workup? Number one point is a careful history. If you miss a careful history, you have missed the diagnosis of your patient. So when your patient walking into the clinic, you want to find out from the patient if there is history of ocular trauma. You want to also find out from the patient if the patient has a previous ocular history. You also want to find out if the patient is a contact lens wearer. And if the patient is a contact lens wearer, what type of contact lens is the patient using? And how old is the contact lens? And also you'll be asking the patient going further to find out what type of solution the patient is using. And also you want to find out from the patient if there are any previous ocular surgeries the patient has undergone. Also, you want to find out if there are systemic medical conditions that the patient has suffered as a result of autoimmune diseases like diabetes, rheumatoid arthritis, tuberculosis. You will also want to find out if there are family ocular history or if there are any family history of blindness. And after a careful history has been gotten, the next stage is a thorough slit lamp biomicroscopy. In your slit lamp biomicroscopy, you will want to do a proper corneal assessment. In your corneal assessment, you'll be looking at edema on the cornea. You want to find out if there are ciliary congestions. You want to find out if there are keratite precipitate present. You also want to know the location of the corneal ulcer. Is it central? Is it paracentral? Is the ulcer peripheral or the ulcer is total? Also, you want to find out the size of the ulcer. Is the ulcer less than 2 millimeter? Is the ulcer greater than 2 millimeter? Is the ulcer greater than 5 millimeter? If the ulcer, according to the standard world classification, if the ulcer is less than 2 millimeter, then it's a mild form of ulcer. But if the ulcer is greater than 2 millimeters, say between 2 millimeter to 5 millimeter, it's a moderate form of ulcer. And if the ulcer is greater than 5 millimeter, then it's a severe form of ulcer. Having done that, it is one important aspect of this slit lamp examination that will help you in your diagnosis is a fluorescein stain. You must carry out a fluorescein staining of the cornea. Here in Nigeria, we use fluorescein strips. I know over there in India, there are availability of rose Bengal stains and also fluorescein strips. So fluorescein strip will really help you in knowing the shape of the ulcer, the size of the ulcer, the intensity of the ulcer, and also help you to know from the shape of the ulcer, it can give you a clue if it is a dendritic ulcer, if it's a geographical ulcer, It will also tell you the kind of organisms that are responsible. And also, like I mentioned, you want to see the anterior chamber and know if there are keratite precipitates present, if there are cells and flares. It wouldn't end there. You have seen these clinical presentations. You also want to find out what is the causal organism. That is why it's important to carry out a corneal biopsy and a culture together with an antimicrobial susceptibility test. Now, without you knowing the causal organisms, you'll be treating blindly and you wouldn't have a success. So it is important that a corneal biopsy, a proper laboratory investigation is carried out. And also why it's important for microbial susceptibility tests so that you will know the exact drugs to administer to your patients. In looking at our management proper, I want us to look at a case study here. A 24-year-old female student presented to the optometry clinic of Okpuala Ngwa General Hospital of the Abia State Health Management Board on Wednesday, 4th March 2020, with complaints of blurred vision, red eye, discomfort with bright light, and severe pain in the left eye. She's been experiencing this pain for the past 4 days, and she reportedly said the pain started after her friend had tried to remove a particle that fell into her eyes while they were preparing for a wedding over the weekend. On presentation, the patient was already on tetrahydrozoline eye drop, analgesic, which is paracetamol, PCM, 500 milligram, and vitamin C. She had been using this drug for some days and there was no improvement. Like I earlier mentioned, one of the predisposing factors in Nigeria is patient prefers to patronize the patent medicine dealers than coming first to the eye centers for first point of action. This patient was using tetrahydrozoline eye drop, which she's not supposed to use. Tetrahydrozoline eye drop is just a decongestant that is used to treat mild form of redness as a result of irritation, but that is what she's using. Now, when she did not see improvement, she came to the hospital to meet us. She, however, denies any significant family history, ocular or systemic health challenges. Her entry VA was 6.6 in the right eye and 636-1 in the left eye. You could see the issue of reduced vision presentation in the OD. And further examination, the external examination, the OD was within normal limits, and the OS shows a slight eyelid edema with circumcorneal injection of 3 pluses, with generalized conjunctival injection of 3 pluses, and central epithelial defect of 0.3 by 2.6. So you see that already this corneal ulcer is already falling into the moderate form of corneal ulcer. And fluorescein stain for this patient showed positive. Now the patient was diagnosed to have corneal ulcer secondary to fingernail trauma. A laboratory investigation was carried out. The cornea was anesthetized using proparacaine hydrochloride of 0.5. And after that, the corneal scraping was obtained using a sterile spatula. Immediately, the specimen was sent to the laboratory for further investigation, while the patient was given a tentative treatment and was asked to report to the clinic after 2 days. The tentative medication that was given to the patient was ciprofloxacin eye drop because it is a broad spectrum antibiotics. Remember, the first line of action in management of any corneal ulcer is a broad spectrum antibiotic, even before you know the causal organism. As long as you have sent your samples to the laboratory for investigation, you wouldn't just leave the patient without a medication. And you might be wondering in your heart, why going into treating a corneal ulcer? It might interest you to know that over here in Nigeria, optometrists that has an OD qualification has a license to manage minor ocular infections. And that is why we do this in our clinics. So we gave the patients a broad spectrum antibiotic, ciprofloxacin, to use. Initial dosage was 1 drop every 15 minutes for the first 4 dosage. And the patient was now asked to taper it to 6 hourly for 1 week. Atropine was given to the patient to reduce the pains and to prevent formation of posterior synecdoche. Penicillin ointment was given to the patient to apply at night, and an analgesic in the form of paracetamol was given to the patient, 500 milligrams, to be used 2 tablets BD for 5 days. And also vitamin C in the form of 100 milligrams was given to the patient, 2 tablets 3 times daily for 5 days. Vitamin C was given to promote wound healing. Now, on the patient first follow-up, patients reported reduced ocular complaints, reduced symptoms, but the patient was concerned over reduced vision. Although the patients reported that the pains have subsided, but she was more concerned about the reduced vision. Now, I want you to know that when managing corneal ulcers, within the first few days, there would be no improvement with the vision, but the patients will notice a reduction in the symptoms. And please, I want you to be conscious at this moment. If you are treating or managing a patient with corneal ulcer, irrespective of the form of corneal ulcer, and you have given a broad spectrum antibiotics, even before the investigative report comes out, and the patient is not showing any sign of response, please refer the patient. Now, the patient entering VA on that eye was still 636+1, but the size of the ulcer has reduced, and the laboratory investigation revealed it was Staphylococcus that was responsible for the ulcer, and the patient was diagnosed to have a bacterial keratitis. Now, a follow-up medication was given to the patient in the form of moxifloxacin eye drop was given to the patient to apply 6 hourly for the next 1 week. And the eye ointment was changed to polysporin B to be applied at night. And an analgesic was given to the patient in the form of paracetamol, 500 milligrams, 2 tablets BD for 1 week. Patient was also asked to continue with vitamin C, 2 tablets twice daily for the next 1 week. Now, on the second follow-up, the patient reported to the clinic after 7 days, and there was an improvement in the vision. You could see the VA of the OS has improved from 636 on the entering VA to 612. An external examination revealed that the circumcorneal injection has reduced. The pupil was dilated. Remember, we had given the patient atropine, so that is why the pupil was dilated. And also the size of the cornea has reduced from 3.2 by 2.6 to 1.2 millimeter by 0.6. Patient was asked to continue their medication, and prednisolone acetate was given to the patient to use 6 hourly for 5 days and review after a week. On the third follow-up day, the patient reported after 10 days, and the patient's vision has also improved with the central epithelial defect almost resolved. Also, the pupil size has almost returned to normal, because in the second follow-up, the patient was asked to stop using the atropine. That is why the pupil size has returned to almost normal. And patient was now asked to taper the prednisolone acetate. Patient was asked to use it 1 drop BD 2 days, and after that to reduce it to 1 drop daily for the next 2 days. When the patient reported on the fourth follow-up, the clinical presentations of the patient was really impressive. The ulcer has totally resolved, and her vision has drastically improved from 636 to 612, and from 612 to 69. And on the fourth follow-up, it was 66 minus 1, and the eyes was quiet. Now, on the patient final follow-up, there was a complete resolution of the eye without any scar. The vision has improved to 66 plus 2, and patients was asked to report after 1 month. Now, I want you to note that the patient's eye resolved without any scar formation. This was as a result of the prednisolone that was given to the patient, because the ulcer was at the central visual axis of the patient, and the patient was given that. Now you can prescribe, it is true that steroid is controversial in management of corneal ulcer, but when there is instances where the patient needs to resume work and the presentation of the ulcer is central, and at the same time, you have seen that the ulcer is beginning to resolve, you can introduce steroid under close monitoring. In most cases where steroids are being induced, it is being given to patients that are inpatients, not mainly outpatient persons. So the patient must be an inpatient, and you must be monitoring the condition closely so that you could taper it when necessary. Now, this brings us to a general approach. That was our approach we used in managing the patient in our clinic. But now this brings us to a general approach. First of all, you as a clinician should have this behind your mind that bacterial keratitis is a sight-threatening complication. And if you don't manage a patient very well, the patient can develop endophthalmitis, or it could lead to a perforation of the cornea. So early diagnosis and treatment is a key to prevent visual loss. In addition, for you to have a successful outcome, you must pay a close attention to a follow-up, also to your laboratory investigation. And please, if there is no improvement in your medications you have given to the patient, immediately you should change it. And wherever you are not seeing any improvement, I will always repeat, please refer the patient. Now, I said earlier on that the general guideline principle is use a wide range of broad spectrum antibiotics. And the 2 treatment options that are available are monotherapy fluoroquinone or a combined therapeutic fortified antibiotics in the form of gentamicin or tobramycin 1.4% and cefazolin 5%. Now, I want you to note here that if you are using a fortified antibiotic eye drop, it is usually applied every half to 1 hour for the first few doses, and thereafter tapered to 2 hourly. And after that, the patient is asked to continue 6 hourly. But if you are using a general broad spectrum antibiotics, it's usually applied every 15 minutes for the first 4 doses, followed by every hour around the clock. Then after 24 hours of applying it hourly, the patient is now asked to taper it to every 2 hours and thereafter to 6 hours. Now, why is it that fluoroquinone is a drug of choice when managing cases of corneal ulcer, irrespective of the causative organism? It's because it has a better in vitro activity against gram-positive bacteria than any other form of antibiotics like ciprofloxacin or ofloxacin. But recent researches has also shown us that levofloxacin is preferred, 1.5% of levofloxacin is preferred over gratifloxacin and moxifloxacin as a result of resistance to the drugs. Now let us see. If your patient or your laboratory investigations revealed gram-positive cocci or gram-negative cocci, gram-positive bacilli, and gram-negative bacilli, what are all the drug of choice that could be used on your patient? If it is gram-positive cocci, you have the regular antibiotic in the form of cefazolin, or the 4th generation antibiotics in the form of fluoroquinolone, or a higher antibiotics in the form of vancomycin. Then if the patient presents with a gram-negative cocci, you can also use a regular antibiotics in the form of cefatriazone, or you can also use fluoroquinolone. And if the patient presents with gram-positive bacilli, you can use fluoroquinolone, clarithromycin, or amikacin. Now, if your patient presents with gram-negative bacilli, you can also use fluoroquinolone. You see that fluoroquinolone is a drug of choice. It's presenting in all cases. That is why it's the first line of choice of drug when managing patients with any form of corneal ulcer. In managing corneal ulcer, there are other adjuvant therapy or treatments that you'll be giving to the patient. You want to give the patient a cycloplegic drug in the form of either atropine or cyclopentolate or homatropine, 2% of homatropine. Now, what is the work or the benefit of giving your patient a cycloplegic agent? One thing they do first is they try to reduce the pains because they are antagonists blocking the neurotransmission at the receptive site of the iris pincer and the ciliary muscles. So they will help reduce the pains, and at the same time, they will prevent the formation of posterior synapse. Analgesic in the form of anti-inflammatory drug can also be given to your patient. It is compulsory to relieve the pain also. And oral vitamin C should be administered to your patient to promote wound healing. The role of steroid is controversial, like I had mentioned in the case we had seen. But it should be used with great caution. It can be used when it is at the central visual axis, but only when you have seen that the ulcer is resolving, and should be used under close management. Also, systemic antibiotics are recommended in cases where there is involvement of the sclera and where there is perforation of the cornea. If you have a patient presenting with impending perforations or perforated ulcer, what should you do? First thing, you should encourage and educate your patients to avoid straining. Some patients can involve in laughing, and the laughing will lead to perforation. So you tell your patient to avoid anything that will cause strain. You can help the patient by lowering the IOP of the patient. And also, depend on the severity, the patient can use soft contact lens bandage, or the patient can benefit from a surgical procedure using penetrating keratoplastic procedure. The patient can also benefit from penetrating keratoplastic procedure if the cornea is perforated, and also a conjunctival flap repair can be done for the patient. And also, in some cases, a tissue adhesive can be used for the patient. Interestingly, bacterial corneal ulcer is a serious ocular infection. I want you to know that it is a threat to ocular surface and also a public health challenge. as a result of being the predominant cause for people in developing countries developing corneal blindness. It is not for you to handle. When patient presents with corneal ulcer, you don't just handle it carelessly. It is therefore suggested that an aggressive treatment should be given to your patient as a clinician. You must follow due processes, careful clinical history taking, thorough slit lamp examination, detailed laboratory investigation, antimicrobial susceptibility test, and educate your patient. Patient education in all conditions of ocular diseases will help you to get a good outcome. If your patient understands the results, why he or she is suffering this, what are the causal organisms, then you tell the patient, this is what you should do. The patient will know the severity of the condition and will understand it. And when you give the patient the medication, the patient will adhere to your instructions and will help you to manage it better. And as a result of that, you'll be getting good results. So I want to say that corneal ulcer is an ocular emergency and should be treated as such. Thank you.
Thank you so much, ma'am. That was indeed a wonderful, wonderful presentation, and it was well detailed and informative. And I'm sure that our audiences have also immensely enjoyed it. And from the team of ForOptom, we would like to thank Dr. Okechukwu for giving us your valuable time and being with us. And also on this note, I would also like to thank our audience for your support. This brings us to the end of this session. We will be back soon with more programs and sessions. Meanwhile, please like the video, subscribe to our channel. You can also visit us at www.foroptom.com and also follow us on social media. This is your host Manashvi signing off. Stay home, stay safe, and have a good day. Thank you.